Yeah, so let's start. So it's a pleasure to have Sudha again, who's already been introduced. So over to you.
Thank you. I was busy trying to destroy the equipment. So yesterday we discussed what the challenges in cancer was, and today we're going to talk about the clinical perspective of what you guys are trying to do. Okay, so there's plenty of machine learning models and plenty of AI talk, but very little, if anything, has yet translated into clinical practice. So in this talk for an hour, I'd like to talk about what it's like from the other end, what people need to see and need to demonstrate for us to be convinced that there is a case to change practice. And this matters to you partly because at the end of the day, you need, if you have an exciting model and you have a nice manuscript, then there are two options, right? You either have to get an industry person to invest in this, to take it to market, or you have to persuade some medics to do something with it. Otherwise, it becomes an interesting piece of work, a useful training exercise, but then what is the next step beyond this? So this is very much the clinical perspective and what the perspective is from our end. So today I'm going to discuss a little bit about diagnostics, about how you make a diagnosis between a positive or a negative for cancer. So I'm guessing this is a classification system, but I don't know that for sure. Understanding that in the context of cancer diagnosis, I'll talk briefly about the challenges of conducting such studies, because we've heard lots about data. We've talked about really cool and clever things to do with the data. But at the end of the day, the data has to come from somewhere. And understanding where it comes from and where that data comes from is so critical that without understanding that, it's very hard to understand the utility of any model that's generated. I'm going to use the example of ovarian cancer because that's my research space. Okay, so we'll do a little bit of clinical speech, but that's really to place things in context. So if I were lying on this here with my head to that end and my legs to that end, and you put a camera inside my tummy, this is more or less what you would see. So you would see a uterus in the middle. Okay, that's where babies come from. You'd see fallopian tubes. This is where, this is the sea anemone type structure where the ova goes into the uterus. This is the ovary where the ova are released. This is the pouch of Douglas, which exists between the uterus and the bowel. This is the large bowel, and the bladder in front you can't see. Okay, so this almond-shaped structure is the normal ovary. Okay, yeah, that's helpful, isn't it? Okay, so this is the uterus. Okay, this is where the babies come from. So you have to, so you're the other way around. So imagine my head is towards you, my legs are towards that end. Okay, so if you looked into my tummy now, okay, this is what you would see in my pelvis. So this is the uterus, this is the fallopian tube, these are the ovaries, this is the large bowel, which is where poo comes from, and this is the bladder, which is where urine comes from, somewhere there, you can't see it. So you can see how small these normal ovaries are, and they are profoundly useful organs, okay? They absolutely one of the most profound organs known to, well, every organ is profound in some way, but obviously I have a particular passion for this. So the ovary has key roles in normal life. It regulates periods, it's responsible for children. It's when it fades in function, it causes the menopause, it's situated in the pelvis. So this is an example of what cancer looks like. You can see this alien, you can't make out anything normal, okay? This is a retractor, by the way. It's just being retracted to show it's a metal retractor in the abdomen. And this is the kind of alien that the ovary will be replaced into. And you have 160,000 new ovarian cancer patients a year. Mortality is high. At best, 3 in 10 women will survive 10 years after diagnosis. So this is at best. So the one thing that makes a huge difference is the stage in which ovarian cancer can be diagnosed. So if you diagnose at stage 1, you end up with a 90 percent 5-year survival, which means that a woman who's diagnosed in 2023 has a 90% chance of living in 2028 if she's diagnosed at stage 1. If you're diagnosed at stage 4, then that drops down to around 15%. So 15% of women diagnosed in 2023 will be still alive in 2028. I mean, the likelihood is that they will be alive on treatment, so it's actually not that they're going to be cured. So it's really important to diagnose early, okay? So this is the sort of thing that, for any of you who've seen a normal CT scan, you don't see a big alien like this. So this is the kind of big alien that you can see when you have cancer. And the cancer doesn't just stay in the ovary, it spreads to every surface in the tummy. So when you have ovarian cancer, then you can have cancer deposits on your liver, on the diaphragm, on the breathing muscle, on every single organ in the body. Okay. So, so this one, this unstageable, where? Okay. So these are people who essentially they are so poorly when they come to hospital, and they are. So you make a guess. You think probably, because you don't have histology. So you make a clinical guess to say, oh, this is a woman. She's got lots of fluid in the tummy. Her CA125, which is a tumor marker, is elevated. On that basis, we probably think this woman has ovarian cancer, but you don't have histological proof. Okay. And the majority of women will actually be diagnosed in, the majority of women will be diagnosed in this, okay, stage 3, stage 4, and this is the kind of group of people. This is the majority of people world over. So there's lots of challenges in diagnosing ovarian cancer. First of all, it's not common. Secondly, it probably doesn't even arise from the ovary. We think the most common type of ovarian cancer comes from the fallopian tube. We don't really understand. You know, yesterday I showed you this beautiful normal to adenoma, to bigger adenoma, to carcinoma sequence. We don't know that sequence for ovarian cancer. And that's well, we have some insights into it, but we don't fully understand how well it develops. Ovarian cancer itself is a heterogeneous disease. There's lots of different types of ovarian cancer. And this screening doesn't work, okay? So this is ovarian cancer. But on the other hand, the whole function of having an ovary is to produce cysts. That's the whole reason why you have an ovary at all. You have to have cysts, okay? Because this is where the babies come from. So you have a lot of women with cysts and a tiny proportion of women with cancer. And the big challenge is, how do you identify this needle in the haystack, this woman who has ovarian cancer from the thousands of women who have ovarian cysts, okay? And you know, we were talking about symptoms yesterday, but the symptoms are very vague. They're very non-specific. This is people who have some bloating, some change in the way they open their bowels or pass urine. They have some fatigue. And it's very difficult to distinguish between the symptoms don't tell you whether you have cancer or not. It doesn't tell you whether this is innocent or not. And 1 in 2 women will have some of these symptoms after the ages of 45 or 50. Okay, so it's really, really very common, and you can't be investigating everybody. Okay, so the way the diagnosis works at the moment is that you have the patient has some symptoms, they present to the GP, and yesterday I told you, I don't know if I had the slide or not, but about a third or fourth of women with ovarian cancer will actually present as emergencies across the world. So actually they'll be so sick when they come that they will die very soon after, because, you know, it's quite challenging to diagnose. So the way it works is you have these symptoms. If you're lucky, somebody will flag in their heads that you have these symptoms, because I told you these symptoms are very common, they're very non-specific. And then you have a CA125 test, which is a protein biomarker test. And then you can have an ultrasound, okay? But the problem with these 2 tests is that CA125 is very non-specific, and it misses 50% of the early stage cancers. So the sensitivity for early stage cancers is 50%, okay? Scans are excellent, but they're not quality assured. So the person who does the scan is at least as important as the scan itself. So when people talk about imaging, I feel like laughing actually, because imaging is highly subjective, including the interpretation of CTs and MRIs, but certainly the interpretation of ultrasound. And most of these cysts, I told you, the whole purpose of an ovary is to produce a cyst. Okay, so most of these are physiological, so they're going to resolve over time. And the incidence of ovarian cancer is highest in women after the age of the menopause, but obviously cysts are more common. So this biomarker is very, very commonly elevated. It goes up in when you have periods, any source of irritation, appendicitis, infection, and there's lots of cancers that also put up CA125. So this is a long-winded introduction to say, is there a point in introducing better tests? Okay, is it useful to have better models? Is it better to have good biomarkers? What, there's lots of different things. So this is one slide summarizing my research program. And essentially what we've done is we've set up a number of studies, okay? And they range across discovery science to implementation science. So discovery science is where you say it's completely blue sky. So you say, let's try and invent a new thing, completely new. So we're looking at nanotechnology, so points of care diagnostics for ovarian cancer. Yesterday, I told you about the supermarket loyalty card data. We do a bit of tech development. So we look to see circulating tumor DNA. We look at urinary metabolomes. We run head-to-head clinical trials, looking at the best biomarker against standard of care tests. And then we take the results of that and we put it into clinical practice. And then we see how well these are actually doing in clinical practice. Okay, so it's a broad range of methodologies, laboratory work, systematic reviews, clinical trials, blah, blah. So I showed you this slide yesterday. And then we've done some systematic reviews that basically try and look at lots of different tests to see what is the best test around. So that's the introductory blurb. So this is where you are. You've got this new machine learning test. How should what do we do then? Okay. So most machine learning stops with, I've looked at this test data. I've tried to say, you've got a training data set, you've got a validation data set, you've got a model. Okay. And then what happens to it? Okay. No clinical practice will change as a result of something that was just on the basis of a training and a validation data set. It needs to prove itself in an independent clinical environment. Okay. So I'm just going to go through some of the theoretical possibilities of how, what are the other things that we look at when we look at new tests. So here I must say before I forget, I would really suggest that before you do any of this, you look at the Equator website, okay? Because the website is really helpful in that it gives you these checklists. And there was a really nice poster outside with the claim checklist outside. So it's really useful before you start your piece of work to identify what type of study you're conducting. And you heard Dr. Tiffin's lecture. And what are the checklists? What criteria do these studies have to fulfill before you're sure that you've conducted the high quality study? And it's useful to do this ahead of time so that you know what you're doing. So what questions might we have about this new test? Okay. So from my end, my question will be, if I do this 10 times, how similar will the results be? Can I reproduce this? How well does this test differentiate between people with and without ovarian cancer? And this is quite important on top of the information that I already have, because your test doesn't exist in isolation. And I think a lot of these things, people say, oh, this is the AUC, it's fantastic, it's superb. But you've got to look at that AUC in the context of what we already knew about this patient, okay? So on the top of this prior information that we had, the pre-test probability or compared to standard of care tests, which this patient would have had, what do these new tests add, okay? And that's quite important because everything has to be compared to what existed before, okay? And how similar is this experimental cohort to the model generation cohort? So this again is really important. Lots of models are generated from hospital data sets. Okay. In hospital data sets, you've got a lot of people with the disease. But if you take that out, say if you have a test and you've generated that model at TMH Mumbai for cancer, almost every person who goes to TMH Mumbai will have very high probability of having cancer because somebody else referred them there. Okay. They didn't go de novo with symptoms to TMH Mumbai. Or somebody somewhere outside has referred them because they've already done a test that shows they've got cancer. So if you generate a model using images from TMH Mumbai, what do you think the likelihood of that person having the disease will be? It'll be extremely high. So you then take that model and then you look at it in, I don't know, Narlikar Medical College. Just, I mean, I'm giving you a specious name. But the point is, you're putting it in a completely different prevalence point. You can't expect that model. The model may perform extremely well. And indeed, some of the algorithms that we use now in clinical practice actually do and have stood the test of time because they have performed extremely well. But you don't know that. And it's really important to understand what the difference is between the model cohort was and where you want to use it. Okay. And my question, which is, if I introduce this test into my clinical practice, is it actually going to make any difference to the way I do things? I've asked for morbidity and mortality, but it could be anything. It could be, will it make my workflow faster? Will it give the patient more satisfaction? Will it reduce my need for invasive testing? It's got to have some clinical utility. Otherwise, it's a bit pointless. Okay, which is not to say you shouldn't do the work, because it's a useful training exercise, it's useful new knowledge generation, but presumably at least some of you want to go on and either go into industry or go into clinical practice and take things into the next space. Okay, and certainly the people who employ you, that will be their goal, which is what, is this worth investing in? So that's the key question. And it's useful to work backwards from that question rather than forwards from we've got a data set. Because understanding the clinical value of why we're doing something is really useful, because it allows you to then, you have to almost start with the end in mind. So there are lots of different things in how we evaluate tests properly. I'm not saying every test that comes into practice, I mean, PET-CT, the evidence that existed for PET-CT before it came into practice was dodgy. So tests get adopted into clinical practice based on sometimes how cool they are. I saw one of my cousins in India, she produced this blood form, and it had all sorts of parameters about platelets that I thought, I didn't even know these existed. So I asked my sister, who's a blood cancer specialist, and I said, well, what does this mean, Sujata? It doesn't mean anything. So people put these things out, and people do them just because they can do them, just because they can ask for a bit more money for them, but they're not actually very useful. So from our point of view, in the ideal world, we have to reduce analytical variability. So what are the sources of variability that you might have? Is this reliable? Is the measurement accurate? So if you're using a biomarker in your model, is it the same platform across all data sets? Will it be the same platform that is then used in clinical practice? Okay, so if you check it on a Roche platform and the thresholds are different for that biomarker, and you're going to use it on an Abbott platform, you've got to configure that in. Okay, everybody gets focused on test accuracy, which is sensitivity, specificity, or as you guys call it, what did I hear? Precision, and there's some other word, but right? Yeah, exactly. From my mind, it's sensitivity and specificity, but that's a tiny proportion of what actually matters when you evaluate a test. And this comparative and incremental test accuracy, is the aim for the new model to replace the current whatever testing, or is it an additive to the current testing? And this is quite important, because the replacement test has to be evaluated completely differently than an additional test. Okay, the way you power your sample size, the way you design your study will be completely different, because then you're looking at either an incremental benefit, which is where the vast majority of testing is, to be honest, or it's a completely, this doesn't work, we change it to something else. Okay, So this is quite important. We then need to look at our end. Okay, I have this new model. It's given me a result. I act on that result. What are the consequences of that? And it has to have some consequences, right? So if you have an X-ray and that X-ray, the model says you've got cancer. I have to believe that X-ray or your model that says this thing has cancer. Then I have to do something about it. So I have to act in response. So when I act in response, how many of these patients are subjected to surgery unnecessarily? And how many of these patients were more accurately diagnosed as a result? So there's a cost. There's always a cost. If you increase sensitivity, you drop specificity. There's a balance between these things. And it's quite important to recognize that. And this is why you have to start with the end in mind. And what happens to the patient who gets managed according to this new paradigm? Okay. So coming back to my question, is there a single study that would answer all the questions we have about the introduction of a model to improve the diagnosis of ovarian cancer? Or should we undertake a series of studies? I don't know the answer to this question, by the way. I'm just posing this out to you. And really I'm kind of slightly repeating myself, but I'm a bit sick and tired of hearing, this is our model, this is our AUC. Okay, what's the next step? So say you have a biomarker which is in your model. Think about all of these things which you must have all done in your undergraduation. What was how was the patient prepared? So if you look at a metabolic marker, blood sugar, it changes all of the time based on what time this blood sugar was taken. Okay. So how is this sample collected? How is the sample transported? Circulating tumor DNA is so dependent on the blood tube that was taken to transport it. Okay. And the validity of the blood tube. So it's these tiny little things that matter. These folks who were doing these test evaluations, all your imaging tests, how good were these people who said this was the lesion they saw? When you get them to annotate stuff, how do you know they are terribly good? And I let you into the secret now. Imaging, terrible for QA, terrible. People say things and you've got no formal QA is built into imaging, which is quite extraordinary actually. And I only figured that out several years into my career. How is the sample request received? How is this sample processed? Tissue processing. Did you know that there is no standardized tissue protocol? So if you look at tissue from X hospital to Y hospital, even the sections that are cut, you don't know. Some hospitals can cut at 3 microns, other hospitals can cut at 4 microns, and you're putting all of this data together. Okay? So it's each and every one of these tests, there is a difference. People talk about, so for everything you do, you have to say, was there a standard protocol by which this was done? Because you guys are putting 100 variables into your markers, models. You don't know which variables are important and which variables aren't, but at least the ones that you think are important, try and find out whether these were generated to SOPs or not, okay? How is the sample transported? So we've got some samples in -20, -40, -80. Luckily, the stuff that we're studying is a bit old, so it doesn't really matter. It probably will function at all of these. But if I didn't know that, I would have to check that the validity of -20, -40, -80 freeze and rethaw cycles. Your samples will be frozen and rethawed, and then those biomarkers will go into your model. Okay? Are they valid? They may well be valid, but you need to check. How is it reported? People don't report to a minimum standard data set. So when you put data sets together and you say, oh, these models, these variables in these models performed extremely well, fantastic. How are they reported? Is there a minimum data set to which they were reported in imaging? And I cannot tell you how complicated it is to get 10 radiologists or 10 sonographers to report to the same data set. Okay. It's a pain in the ass, basically. So for QA, subjective versus objective tests, and this is really important. You really need to figure out, if you're dealing with a subjective test, who the hell has QA'd the test? Who has annotated the samples? How good were they? Was there an inter-observer variability in that? So inbuilt QA for subjective performance extraordinarily is very rare in medicine. It exists for some things. So laparoscopic colorectal cancer, extremely, well, in the UK, it's extremely QA'd because you have to pass, you have to be QA'd. Robotics, extremely well QA'd. But there is a lot of stuff. I mean, I would say those are the rare examples. For the majority of stuff, actually, medicine still is very subjective. So where is the QA for annotation of images, annotation of pathology images, annotation of radiology images? Okay, this is quite important. It's often not transparent that there was ever a QA process in the first instance. And then cohort conditions can change. So you have this model, you introduce it in clinical practice, or your company buys it and they say, oh my goodness, this is a fantastic model, let's put money into it. And then you have an influx of refugees. Your model wasn't built to take that, okay? Or you have some change in some parameter, there were floods in the system. And so as a result of that, people had more diarrhea and their metabolic conditions changed. The point is that if you have a model that's introduced into clinical practice, you then have to keep QAing the model and keep checking that because your cohort changed and something changed in the system that you weren't aware of, something in the ecosystem or the priors changed, that it performs as well, okay? So it's really important that your job doesn't stop just with the generation of a model. First of all, you have to validate this model in clinical practice. Then you have to keep QAing the model, okay? So you have to ask yourself, is your test affected by inclusion of variables that are dependent on patient factors? So metabolic models will change based on time of day, fasting, when they last ate, sample technique, delay in technique, skill of ultrasound operator, and some things are less objective, some things are more objective. And you have to do all of this range finding before you can be certain. From where you sit, none of these factors probably make a huge difference to you, but it will make a difference to how the model performs in reality. So repeatability in the sense of the variation in measurements taken by a single person on the same item and under the same conditions, the estimate of the measurement error, the coefficient of variation, the reproducibility, the measurement accuracy, and any safety analyses. All of these matter. So I'm sure that any of you who is doing model generation knows all about model accuracy. Okay, that seems to be the thing that people know the most about. So I'm going to just quickly go through this. But in the context of a diagnostic space, this is the question. This is a comparison. You know, it's how well a test, an index test, has performed as compared to the standard of care test against a gold standard. In my job, the gold standard is histology. It could be gold standard. The gold standard could be anything that is commonly seen as the best test available for a thing. Okay, and in doing this, there's an explicit recognition that even the best tests will make errors. Okay, and there is a trade-off between the sensitivity of a test, so how good the test is in picking up the true positives, versus the specificity of the test, which is how good the test is in making sure that the number of false positives is reduced. So basically, this is the way that test accuracy works. You have a cohort of patients, you do lots of tests on the patient, and then you check it against the reference standard. And the components of a model of asking this question is you ask yourself, who are the patients? And getting this inclusion and exclusion criteria correct is absolutely vital, okay? And if the inclusion and exclusion criteria are different across different data sets, then you're looking at heterogeneity in the system, okay? There's no doubt about that. I mean, it's very rare that all inclusion and exclusions overlap. And usually by the time that exists, that field is quite mature, but it's still at least worth knowing that and pointing that out in the limitations that your inclusion and exclusion were different. What was the prior tests? I've already discussed what the prior possibility of these things were. What were the tests being evaluated? What is the test trying to detect? What is the reference standard? and then the outcomes that everybody is so familiar with. So essentially, test accuracy is the cross-sectional point. What proportion of those, so the sensitivity is a test characteristic, and it asks how good is the test in picking up, in correctly identifying those who have the test, those who have the condition, and specificity is how good is the test in identifying the people who don't have the test as correctly not having the test. And so, I mean, you guys look at this slightly differently. It's called, I mean, we call it a 2x2 and you guys call it something else, but essentially it's once you've done the study, everybody gets the index test, everybody gets the reference standard, and then based on, so then you group it into two groups, everyone gets a reference standard, and then you say, is your reference standard positive and your index test is positive, then you become a true positive. If your standard is negative and the test is positive, then you get a false positive, and then the converse for the false negatives and the true negatives. And then you can work out what your true positives and your false positives, your false negatives and your true negatives. And then that is sensitivity, that is specificity of a test. So once you've done this, you can then work out what these are. And obviously, the lower you can get your false negatives, the better your sensitivity. The lower you can get your false positives, the better you can get your specificity, because it's only a it's only a formula. The other things that we use to look at diagnostic accuracy are PPV and NPV. And remember, sensitivity and specificity are performance characteristics of a test or a model. However, PPV and NPV are what it matters for the individual patient. So PPV and NPV are highly prevalence dependent. So the higher the prevalence, the better the PPV, the lower the NPV. And this really matters because if you're trying, as I said, if you're trying to get a model to work in a place with very high prevalence, but actually you want to take it into community, then you have to accept that your model is not going to perform as well. So you have here, which is what a random classifier would do, which is 50%. And then this would be the best test because it's better for sensitivity and specificity. And this is, you know, so if it's under this, then it's worse. The higher it is to the point, to the one here, then it's the better test. And people come up with ridiculous ROC curves that are, you know, almost at 1 for both sensitivity and specificity. Those are not true. It doesn't exist in reality. There's something wrong with the data set. So let's talk about test errors, okay? And you have to accept that all models have errors. Okay, you have to go into this thinking, okay, I'm not going to get, it doesn't exist. These models, you know, there is no model that exists in that way. And there's a consequence of this. So you can gear it, you can gear your model so that sensitivity is very, very high, okay? So that it picks up all the true positives. The consequence of that is that you'll have lots of people who will have testing. Lots of people who are flagged up as having cancer when they don't have cancer. And that's a lot of anxiety. And you can say, I don't care. If I have a 1% risk of having cancer, I want to know. But that might be horrendous for people because 99% of people will not have cancer and they'll all get all these unnecessary investigations and all this unnecessary operating. You can gear a test such that specificity is very high, okay? And if you do that, you have lots of people who, so from a healthcare perspective, increasing specificity is amazing because then you reduce the number of people coming to clinic, but you also miss cancer. So it's always a trade-off between how accurate your test is versus how precise your test is. And you just have to live with the consequence of that. So in any model study, you have to ask yourself, what is it telling us and what is it not telling us? So I've basically glossed over this, but my slides are on reference if you want them. So finally, the bit that matters the most to us and where we probably know the least, which is what changes in clinical practice as a result of this test, okay? So for this, you know, this bit we have a lot of, There's a lot of information in public domain. As a result of this new model, what am I going to do with the result? I have to do something, right? Otherwise, there's no point in doing something, running a new test. I have got to take that test and do something with it. So once I've done that, then there are harms and placebo effects of having the test. Then I have to act, and something changes to the patient as a result of my actions based on this test. So in a sense, there's no, really what is important is not an improvement in accuracy. What is important is, as a result of this change in accuracy, whatever that change is, what is the downstream effect to the patient as a result of this test being available? That is the question. That's the real question. What is going to happen? Are we going to reduce? Are we going to pick up more cancer and see more patients? Are we going to do things faster? What is the end result? Okay. So basically, this is basically the summary message, which is that accuracy is only a component of evaluation. Sometimes technology changes very quickly, and people were pointing out that PET-CT was adopted quickly, and imaging modalities change very quickly. And that's really challenging in some ways, because these things get into clinical practice without really understanding how well these things work. In the ideal world, we would change tests and we would randomize it. So you'd have test treatment trials, but they're exceptionally rare. And you can use decision models, but they're the next best alternative. So you need to place this model in the context of clinical use. And if you take home one message, that's basically it. So in the next 5 minutes, I'm going to talk to you about, now that I've talked to you about the clinical context, I want to talk to you a little bit about what it's like collecting the data to give you the data, okay? So everyone here receives data, which is amazing. Think of the poor person collecting the data. In order to be able to collect the data, you have to define a research question, okay? You have to design the study. You have to sample size it. You have to adequately power it. You have to secure the funding for it. You've got to get the ethics for it. You have to design the data collection form. Then you've got to recruit patients. Okay, and that's not easy. Those who run trials know that very well. You've got to manage the study, make sure that you run it under governance. Data standardization often doesn't exist, because yes, you have data standardizations for disease conditions, but for symptoms, you actually don't have data standardization. You can have some things like pain scales and diarrhea scales, but the majority of time we say, are you bleeding? What is bleeding? How much bleeding is bleeding? How much discomfort is discomfort? Your discomfort might be my excruciating pain. So it's we don't have standardization for many of the terms used in medicine. Things change along the way in long trials. You end up with complex pathways, so you lose data, and you don't lose it because you've lost patients, but you lose it because in a data set, nobody has talked to the statistician to say outcomes are in this field, and this field. So there's data loss along the way. And clinical sense checking of the data, because it's not a medic who's actually collecting the data. The data is collected at a different point. It's transcribed onto several things. Then by the time the statistician gets the data, or you guys get the data, there might have been errors in sense checking the data that have acquired, that have come through the pathway. So there's lots of data cleaning. And then how much data is enough data? In the ideal world, people who are doing machine learning, they say, give us as much data as you like, as many variables as you can possibly give us with as big a sample size as possible. On the other hand, some poor person has to collect this data. Some poor patient participant with whatever disease condition they have to are generously donating this data, okay? So getting this poor person to complete 15, 20 minutes worth of data collection over time is challenging. So there's this conflict between minimizing data burden. And remember, every time you collect a piece of data, you then have to query the data. You have to clean that data. You have to make sure that data makes sense. So there's this conflict between minimizing the data burden on participants versus having enough of a data set so that you can do lots of interesting work, not just primary outcome, but lots of secondary analyses. So the moral of this story is talk to the medics, okay? It's not enough to just say, oh, we keep clinicians in the loop. If you don't have a medic who's center defining your clinical question, then I would suggest to you that go out, find your nicest doctor you can find, buy them a drink, sit them down and say, please help me, okay? So patient-public engagement is actually quite important, and it's really important for funding applications. And actually, it's really important in the way that you set up a study and you run that study. So that's something that, I mean, I haven't got time to go into it, but it's really incredibly important. And I've seen a few things in the last 4 days that makes me worry how much of this is clinically defined. If you don't have clinical definition, as I said, you'll get a nice poster, you'll get a nice paper, but you won't get anyone to invest money into your idea, and you won't get any onward planning. And the person who gives you the data, treat them nicely, okay? Because they've worked very hard to collect that data. So I'm going to stop there now. I've got some reference materials. Happy to take
Yeah,
questions.
I expect lots of questions, but thanks
yeah.
for a very thought-provoking thought that should keep us honest. Just to comment that a lot of what you said might not just be available to machine learning models, but to
yeah.
diagnostics in general, right?
Yeah. So
Yeah.
my slide comes from diagnostics, really. I've tried to extrapolate it to machine learning.
Right. Okay, I saw some raised hands. Okay, you first.
No, thanks a lot for, again, beautiful talk. As in, I felt that clinician really trying to get to us is more we going to clinician to get the data.
Yeah, so if you can't get the senior most person involved, there's lots of junior medics who would probably they may not understand it that much, but you need to have medics involved. Otherwise, you will end up with stuff that you'll make errors along the way, really. So you've got to somehow buy them lots of coffee, lots of alcohol, whatever it is, just get them involved, basically.
So I have 3 questions actually. And the first question is that you talked about as a machine learning engineer, how much I'm adding to what you are seeing. Say, for example, you see PET images and I can predict it accurately. Accuracy might be more, but like it really, we don't know how much it adds to that. And that's the real question. But again, I have one thing which I wanted to understand from your perspective, that there are certain things which doctors might do empirically, say, for example, drugs. So like I worked in rheumatoid arthritis, so there was one certain drug which were empirically given, but like there are lots of inhibitor, like JAK inhibitor is there, other inhibitor. So I wanted to understand the empiricalness that currently exists in every cancer, which we can exploit to actually work on. So that is my...
So I think that's a really good question. So the way medicine works is you have lots of clinical trials. Then you have guidelines that synthesize these trials and say, okay, for a given condition, you have all of these different options, and then you can use these. We don't have, you'd be surprised to see, objective decision analytical tools, which is what you're talking about. For a given patient with these parameters, these are the sets of drugs that might be most useful. When you send a urine off for culture and sensitivity, you get a set of, you get a very clear set of, these are the ones that are sensitive, these are resistant, try this. Most clinical scenarios, you don't have that, particularly in complex scenarios, you simply don't have that. And these are these are absolutely ripe for machine learning models, but you can't get it done unless you have senior clinical input. So don't get me wrong. I think all of this work is worth doing. I think all of this work is definitely worth, I mean, this is the future. I genuinely believe that medicine is going to be transformed by this space in the next 10 years. Otherwise, I would not be here, okay? But it's only going to happen if you have complete and utter alignment of purpose between medicine and you guys, because otherwise, you simply won't understand you'll have people in 2 different spaces not talking to each other. It's a bad thing. Do you understand? Yeah.
As in, say, for example, even if there might be treatment response data, say, as in with clinicians for the first line of drug, right? So how much are those data available in terms of like,
They are available in EHRs. They're not often objective or standardized. So for CT, for instance, there's resist criteria, but resist criteria are not used in terms of normal clinical context. So they are available in EHRs, but they're often in PACS systems. So the challenge is, and I think Nikki was talking about it earlier, Dr. Tiffin was talking about it earlier, where you have clinical data, you have imaging data with the reports, and how do you, so that sort of multimodal integration with patient survival, I think. But the thing is, in India, I think there's a unique opportunity because like the NHS, for instance, it's a lot more complicated because these are legacy systems. You know, these guys have been around for donkey's years. These are legacy systems, very hard to integrate. But new systems, new hospitals, it's easier to integrate this kind of thing into your going forward. Yeah, this data exists. It exists. It just exists in different bins in various different hospitals. That's a problem.
yeah, so like, okay, fine. So that was my, and like how to get those data, but I think that can be done.
Yeah, you need to speak, you need to find some really nice and keen medic who wants to work with you.
So
It's really
I
important.
have another second question. My second question was more about, say, for example, as a machine learning engineer, I've developed a test, and
Yeah.
say, for example, it's a good test, and currently it is doing empirically. So usually doctors use NICE guideline.
Yeah.
Not all doctors, but maximum
Yeah,
doctors use
mhm.
NICE guideline. So how a machine learning engineer would like to introduce their test, say, for example, with
So I just boasting here, but so my work has changed nice kind. So, but that was in the context of surgery, not diagnostics. So, so NICE in particular, they've got a diagnostic panel. So they actually have a panel for diagnostics assessments. It's a tough panel to get into. So basically you flag up, you can write anybody, any company can write to them. If they have, if they're in the UK, any company can write to them, a company with a test that's available in the United Kingdom. I think I need to check that, but basically any company can write to them to say, we have a new test. We have this use case. Could you consider assessing it, please? And if they think it's valuable enough, they will assess it. But to satisfy NICE criteria, and it's available, it's publicly available, the criteria that they will assess it on. You have to be, it has to be really rigorous.
okay, and my
I'm a bit conscious that you're hogging the mic, actually. We just need to, I'll come back to you.
Go ahead.
Hello. When you talked about your sister's experiment where you mentioned that she has this platelets and all those parameters, but those were not useful. How do you know that those are not useful and like that is unnecessary?
Okay, so this is a good point, and it's always a bit stressful when you have a completely new thing because you don't know if that new thing is going to be the thing. But you can only go with what you currently know in the clinical space. If that's a completely new thing that tomorrow people find is completely evidence-based and robust for some new thing, then you've made the mistake. So most medics have to live with the fact that they can only go with what they know at that current space of time, and they don't know what the association of that is in a year's time. And one lives with the fact that our knowledge is subjective.
See, some like in some study, I'm not sure, but theoretical biologists would say like this can affect like since for the ovarian cancer you don't know the cause and the stages and all you mentioned, right? So like this platelets and all can affect these things, can be
so-
possible.
So I hear what you're saying. So a given medic for a given patient has to make a call between how much they want to investigate to get to a place. Okay. So a test in isolation, even if it's a new test and someone says, oh, this is fabulous for X, you need to have enough data in the system to be able to act on that test. Okay, that's point one. And point two, you can't take a single parameter in isolation. Suppose the person's completely hale and healthy and they've got one funny test that you don't know about, there isn't enough data in the system. The danger is that you over-investigate. And the more you investigate, the more you have false positives. And then people go down a road that is expensive for them, that is quite invasive for them. And a year down the line, they're no further forward. So there's lots of debate now as to the over testing. So you test for stuff, you do stuff to protect yourself, you cover your back. So you do more tests, more tests, more tests. And in the end, the person who's paying the price is the patient, right? And it adds to the cost of treatment. So there is a balance to be had. And every medic lives with, okay, I might miss this 99% of the time, and that's a subjective estimate. I'm probably right. So I'm going to choose not to take this any further. Does that make sense? So this is a conceptual difference. You guys see in numerical clarity of thinking. It's either 1 or 0. I have a daughter like that. She gets really upset. She's young, she's 14. She gets really upset as whether it's 7.343 or whether it's 7.34. For me, somewhere in the region of 7 is good enough. So, that's a conceptual difference.
Anyone else?
Okay. You mentioned that there is a trade-off between specificity and sensitivity and all of that. So what is acceptable for a screening test and for a diagnostic test?
So this is a tough question to answer, because it depends upon how common that condition is that you're screening for, how frequently you're going to be running that screening, how acceptable that screening test is. So for cervical smears, for instance, cytology is only 70% sensitive at any given point in time. Okay, but actually, because the plan for the NHS screening program is they keep repeating the test, and cervix cancer takes a long time to develop, they trade that sensitivity off by saying, okay, if we didn't pick it up in 2023, we'll pick it up in 2026. Okay, but it depends a lot on what that clinical context is for that test. And for diagnostics, if it's cancer, you may want to gear your sensitivity at 90% or 95%. But if it's something less, for early, I'm thinking of a suitably not worrying condition for IBS, for instance, irritable bowel syndrome, your sensitivity might be much lower, because you think, well, it doesn't matter if the patient has to wait for another 12 months before she gets a diagnosis. Again, I work in a public health sector funded system. Money matters for us because the state pays for everything. So there's a huge cost effectiveness. What is the cost to the system for this? In the private sector in India, it's the patient who's paying. Okay. So it depends upon who is paying for a test, where this place is, what is the cost of missing the test positive. For a genomic test, you may have a threshold of 10%. So you set your sensitivity to pick up. So you would only do the test if you think this person's at least the 10% of these patients are likely to be positive, because there's cost to the patient for testing positive. So it's an impossible question to answer broadly, but it's disease specific, it's prevalence specific, it's a very complicated condition. And this is, in a way, this is really hardcore knowledge as to where you want to, this takes hours and hours of discussion with experts to get to that point. Okay.
I can, if I may make a comment on that and the screening part specifically. So we talk, I think Saurabh introduced either Saurabh talked about Bayes theorem and the specific example of supposing, so I'll talk about true positive and false positive rate instead of sensitivity is related to the
true positives,
yeah. Anyway, so supposing a test has 99% true positive rate and 1% false positive rate, and you think it's a very good test, but for screening purposes, you're screening for a disease that occurs in 1 in a million people, and this test shows up positive. Do you believe it? According to Bayes theorem, you don't. So for screening, you really need to be skeptical, especially for rare diseases.
Yeah, that's a good point. Yeah, that's a very good point.
But of course, when a doctor prescribes a test, then it is not some random member of the population. That person is presenting symptoms, and then all that prior knowledge of the doctor should come into what the doctor decides to do with the test results. So to come back to, you were saying something about there aren't standards for diagnosis and so, but a lot of it is individual domain knowledge of a doctor. And just recently I saw that
Yeah,
3 doctors see the same CT scan and say 3 different
That's
things.
right.
So
that's right.
somehow I don't think we are, or maybe we should be at a point of automating the diagnosis.
So-
Yeah.
So I think where we will be is triaging of diagnosis. I don't see a reason why a chest X-ray needs to be read by a doctor. I don't understand it. So for normal chest, to say that a chest X-ray is negative, why do you need a doctor after 10 years of training to say the chest X-ray? I'm not saying chest X-ray is positive. If you have a lesion, then you may, then you may need to have expertise in it. But if the chest X-ray is absolutely negative, so you could have a system where you pass 100 X-rays through a model, it triages out 70% of people because the likelihood of them is negative. And then you have experts look at 30%. So I certainly believe that automated systems have to come in for triage, and that's for pathology as well as radiology.
Yeah, I think that's exactly where they would be.
Yeah.
Even for positive cases, if it's
Yeah,
a cheap
possible.
automated machine learning based test that gives you some indication that you should pursue,
Yeah.
then you can focus more sophisticated screening on them, maybe something like that.
I completely agree. I think I don't have as much knowledge of radiology. So my understanding, I was speaking to this really expert professor of radiology from Chicago or MD Anderson, and he said, the reason why these models are not in clinical practice is not because the models are not good enough, or even that the radiologists won't accept them. It's because the IT infrastructure doesn't allow talking of the models to PACS systems very well enough. And there isn't enough capital investment to change the infrastructure.
Okay. Any more questions? Yeah.
Just about.
Fine. Fine. So I have a very general question, and the question is that, like, from the ethics point of view, like in the patents, we have to take the geographical permission. Like if I've taken the patent for India, I cannot. It is not applicable in US, right? So do that apply in the form of ethics also? Like suppose that I'm going to design an experiment.
Ethics is institution specific.
Okay.
So
And-
ethics is institution specific. So in the UK, ethics is UK specific. But that's because it's one country and they put a lot of effort into. So if you have UK ethics, then in theory, it can be done to any United Kingdom participant. But that's not how it works in most places. So Australia, it's province specific. India is institution specific. So ethics is very specific to whichever country and whichever place you're working.
So suppose that, like, if I want to conduct a survey and that survey wants some private information of the subject, but that information is very like general ones. So in that case, do the permission be required from the ethical point of view or not?
So I don't really know the answer to that question. I think it's unusual for anything that goes through health. For us in the UK, you need to get patient, you need to get ethics for it. You can get around it and make it a bit less difficult by getting aggregate data rather than, so instead of getting age, you can say, give me your age band. Instead of giving date of diagnosis, you can have a date year or something like that. So you can minimize your likelihood that ethics will object. But it's unusual for ethics not to be required if you're going through a health system. If you're going directly to the community because you're in Reliance or somewhere and they're asking customers, I don't know about that.
Thank you, ma'am.
Anyone else? Or you want to follow up? Make it quick because we are about time for the next.
Yeah, so my last question was data standardization in terms of symptom. Like, how do you see that progressing and what are your views? Because quality of life is something which is kind of subjective, but we want to measure.
So quality of life, it seems to work out. It depends upon your power and your sample size. These things are quite standardized. So the quality of life, because they've done lots of work in the standardization of the questions, then it kind of evens out because you're going to a very specific format. there is some subjectivity to it, but often it's because patients have to, quality of life, all questions have points, right? So they, it's not, they don't say how much discomfort are you in. They make you give, there's a numerical score for that. And then there is scoring systems to convert those into the actual output, the actual result. So yes, there is subjectivity in it, but it's still better than asking people randomly, do you have headache? Because, yeah. So that's probably standard enough.
Okay, so with that, let's thank Sudha for two wonderful talks.
Thanks.
And